these are our presenters today, and I'm not going. What I'll do is I'm just going to say that we've got Sonia, Jeanette, Erzsébet, Lizzie, Wendy, and Michelle. They're all going to be presenting parts of the webinar, and they will introduce themselves properly as we go through. And we've also got Beth Osborne, who's our project manager and our tech support for today. Next slide, please, Beth. So I'm just going to give you a little bit of background of why we're here today. And some of this information, you know, a lot of you will have heard of already, but as you know, the confidential inquiry, which was 10 years ago now, started to give us information about why people with learning disabilities were dying. And then the leader reports, the annual leader reports, which started about 6 years ago, really give us an annual report using all the reviews that are done into the deaths of people with learning disabilities. And that really gives us a lot of information about what services people are getting, what's not going right, what is going well. And those reports for the past 6 years have consistently highlighted that pneumonia is the leading cause of death for people with learning disabilities. And that in some ways is not too surprising, but what is surprising and concerning is that the proportion of those deaths that are deemed to be avoidable and premature too early. So it's really all of this kind of information that we've been able to have access to over the past 6 years has really helped us focus in Sussex. And I would say in the last 6 years, our service has been focusing on looking at the evidence, working with other services like the service at Guy's, who developed their respiratory pathway, and they shared it with everybody. And we've really been working to try and improve the services that we provide for people's respiratory care. And then quite sort of excitingly for us, in the last year, NHS England have produced this Right Care Toolkit for pneumonia, which is a really comprehensive guide for services about what they need to be doing about pneumonia for everybody, about preventing pneumonia for the whole population. And then in the last few months, and actually last month, NHS England had commissioned the British Thoracic Society, and they produced these 2 documents. One is about aspiration pneumonia, and one is about pneumonia in people with learning disabilities specifically. So those 2 documents only were finally published last month, and we've been looking at them carefully. And they really act as a guide for services nationally. So it's really put all of this information on the map and highlighted it as very important and something that we can really do something about. So for us in our service, we've also been given some money by NHS England quite recently to do a project. And at the moment, we're running that project in Sussex, and this webinar is part of that project. And I think Beth's going to share, we've got a link, at some point we will put it in the chat. We have a feedback session in May to let you know what's happened and the outcomes of the project. But we've been talking to lots of people, carers, services, and all the respiratory services across Sussex to try and map and find out what's happening. So we'll be able to share that with you towards the end of May. So that's all I'm going to say now on the background. That's sort of why we're here today, really. And we're very excited that we're able to put this webinar together and share this information with you. And in a minute, I'm going to hand over to Sonia, who will introduce herself, and she's going to talk a little bit more detail about LEADER and some of her own personal experiences. But before then, I think we're going to have the poll there. So what we're going to do is ask you some questions, should come up on the screen, and it's really to get an idea of how you rate your knowledge in relation to the information that we're talking about today, the risk factors about pneumonia. So it's really about your knowledge about what are the risks for people when you think about developing pneumonia. How would you rate your knowledge at the moment? And if you see those boxes, those circles on your screen, if you click on one as to how you would rate yourself, it won't get shared with everybody in terms of who you are, but we'll just collate the percentages at the end of people. And we're hoping that this will give us a feeling for the impact of the information that we're going to be sort of sharing with you today. So
yeah, we've still got some answers coming in. It's nearly, I think nearly everybody's done it who's able to click on the screen. I think that might be it.
Great. So we'll just quickly share that and have a look how you feel before we start. Okay, so we've got a bit of a mix, and most people are sort of sitting around the middle. So some people are feeling knowledge is not very good, and then we've got the majority of people sitting around the fair to good. Some people feeling that the knowledge is very good. So hopefully we'll be able to do that at the end and just get a feel for whether or not that's changed for people. Okay, thank you for that. So I'm going to now hand over to Sonia.
I am Sonia Reid. I am a self-advocate and advocate for other people with learning disabilities. I am a member of the Informant Matter team, co-chair of the East Sussex Learning Disability Partnership Board. I was recognised as a national leader, disability leader in 2021 for my work in the community. I have been a gold medalist in the Special Olympics and assistant coach. I feel it is important for people to keep healthy. Unfortunately, I cannot do Special Olympics anymore because of a knee injury, but still like to do swimming, football, and the gym. The Informant Matters team are a group of adults with learning disabilities who work with East Sussex County Council and East Sussex Learning Disability Partnership Board. We are self-advocates and have peer advocates, and we speak up for other people with learning disabilities. We advocate for others because we want to make sure that people with a learning disability have their voices heard on issues that are important to them. We know that people with a learning disability face many inequalities, and health is the biggest. We want people to have a say in how services are run and how improvements can be made to support people to live a good, healthy and happy life. One of the key reports that Martin just talked about is Leader Report, and we were going to show a video about the leader, but sorry, the sound wasn't loud enough. We are going to share the link in the chat for you to watch another time. The video is by self-advocates from National Inclusion North, Stop People Dying Young group. Tell us more about Leader and their thoughts and views on this and what needs to be done. We know that Leader, that people with learning disabilities are still dying earlier than the general population. 37% of adults with a learning disability live beyond 65 years of age, but this is compared to 85% of the general population. The most common reasons of deaths and people dying too young and too early is delays in problems and finding out what is wrong or treatment. Problems finding out people's needs and making sure they get suitable care, their needs change. We know that Leader found a new pneumonia, chest and breathing issues add to the deaths that could be prevented. Pneumonia is the most common cause of death amongst people with learning disability, and bacterial pneumonia account for a lot of these. In adults, 24%, and a further by food and drink going down the wrong way, which can lead to chest. 49% of the deaths from pneumonia were preventable or avoidable, compared to 22% in the general population, that is over double. People with a learning disability are dying too young from conditions that can be prevented. The Informing Matters team want to help people with a learning disability to live a good and long life. We want people with a learning disability to have equal access to healthy diet and the chance of exercise. We want people to be supported to talk about their symptoms or when they are feeling unwell or uncomfortable. We want to help make it easier for people with a learning disability to get good information about this. We will be supported to develop easy read information to support people understanding.
Hi, I'm Jeanette Gallivan-Young. Hopefully you can hear me and see me. I work with Sonia and the Involvement Matters team, and we have some experience of Sonia's input and the team's input around annual health checks, and wanted to share some of those experiences with you, if we may. I think Sonia's going to start us off.
I have mine done. I'm in supporting living, so the nurse makes 2 appointments. Half of the tellers are seen on one day and half on another day. I didn't see a doctor as part of my annual health check. They took my heart rate. This was due to one of my medications. They took oxygen level, blood pressure. They didn't weigh me, but they asked the staff to weigh everyone and tell them their weight. I didn't really ask me many questions about my health. The first annual health check I had done was with a doctor and nurse. I think this was about 6 years ago. I had a medication review as part of STOMP, and I would like my medication to be looked at again. And since that happened, the person had the medication done. So they on different medications, and it helping them a lot.
Thanks, Sonia. Then we got some other feedback and experiences from the group, which I'm just going to read out some of the experiences. The surgery rang me last week. I went to the surgery. They did my weight. They asked me to have a blood test, but I refused. I've passed out twice before, so don't want it. They took my blood pressure, asked me if I drink. They asked about mental health and lockdown. I told them how lonely I felt in lockdown. I saw a doctor and I had to wait for half an hour. Another person had said they weren't sure if they'd had an annual health check or not. And then somebody had said it was completed recently, lots of questions asked. The doctor did my check and not the nurse. It was thorough, but it hadn't been completed for some years. I think the next one's for you, Sonia.
Yeah. Another 2 people said, I went to surgery today and I saw a nurse practitioner. They took my blood pressure, weight, height, and weight plan. They asked me about mental health and how I was feeling. I went through a preparation document over the phone with my home manager. I received an action plan, which was a plan of my weight and other goals. Another person said I had annual health check. It was arranged through my support and living team. I didn't see a doctor or a nurse came to my flat. They took my blood pressure and asked me quite a lot of questions. I wasn't given the easy read information or the annual health plan.
Thank you, Sonia. Next slide, please. Yeah, I think from the information we've got, we found that most of the people we talked to have had annual health checks, which is good. Only one person was not sure. Everybody's experience of annual health checks has been different, which is something that was quite key, and the consistency around the annual health checks and the kind of information beforehand and who did it and how it was arranged was different for everybody. So it felt like the consistency around those was something that may need to be worked on so people know what to expect. Only one person out of, I think there was 12 people we'd spoken to, had received a health action plan, which was something we'd flagged with the health facilitation team and other health colleagues. And there was no easy read letters or information shared. So there wasn't any easy read letters for inviting to the appointment or information shared within the appointment or afterwards, except for the one health action plan from one person. So we've spent some time, and we meet with the health facilitation team in East Sussex regularly every few months, and we work together with the team to support future work in helping to address some of those health inequalities and making access better to healthcare for people with learning disabilities. And the Involvement Matters team have already fed back this information that we've just shared about what's good and what's not so good, and their experiences of annual health checks, which the team have shared with the annual health check steering group as well, and will use this feedback to help make things better in East Sussex. So back to Sonia, I think. Next slide, please.
How does someone's respiratory or breathing problem affect their life? For me, I have asthma and I get out of breath a lot. Even things like getting dressed or putting my socks on can cause me to get out of breath, let alone walking up a hill or exercise. I started to impact on my Special Olympics and coaching, and along with my knees issues, I have to stop doing this. I'm on inhalers, Ventolin and prevented one. I can be prone to chest infections, and I have to have antibiotics to help clear up a chest infection recently. But I have been lucky. I haven't had to go to hospital for my chest yet. I have an asthma review every year. The practitioner nurse check how my asthma is, check on my pre-fire reading, just ask how my asthma affects me, and how it affects me doing my exercise. As I said, experience problems affected me in some ways, but lucky not having a major impact on my life so far. For others, it could have a big impact. It can affect their physical health with chest infections, hospital admission, always have a cough, noisy breathing, and finding it hard to breathe. Pulling at the back of the throat, pain, and other illnesses. It can impact socially. People are able to meet with others due to the way they feel, tiredness and weakness, noisy breathing, pulling, drooling, make meetings others more difficult. It can also affect their mind and well-being, feeling like we are suffocating, feeling frustrated, unable to cope, feeling out of control, feeling anxious and scared and distressed. Thank you all for listening. The most important, let's continue to work together so that people like me with a learning disability get to live a good, healthy and long life. Thank you.
Hi everyone, my name is Elizabeth. I'm a physiotherapist in the East Sussex team, and before I start my presentation, if Beth puts it in the next slide, lovely, thank you. I just would like to give you a big thank you, Sonia, for sharing your experience and also sharing the feedback about the annual health check. Because it is in the BTS guideline, there is huge emphasis laid on annual health check and the importance of it in managing pneumonia for people with learning disabilities. And I know you have to leave earlier, so thank you so much for presenting for us today. So people with learning disabilities have worse health than people without a learning disability and are more likely to experience a number of health conditions. There are a number of factors where health inequalities are presented, and one of them is diagnostic overshadowing, which is when assuming that a behavior of a person with a learning disability is part of their disability without exploring other factors such as being physically unwell. It may be preventing clinicians to recognize deterioration or may result in delay in initiation of key treatment. Another factor is communication difficulties, if someone unable to express themselves, because we know that 80% of people with severe learning disability never acquire effective speech. Lack of awareness of the issue, so not being aware of the risk factors for pneumonia and therefore not having appropriate management plan in place and referral to special services also contribute to health inequalities. Same as access to health services. So people with learning disability often don't have formal respiratory diagnosis and therefore unable to access some services commissioned for specific conditions such as asthma or pneumonia or COPD. Next slide, please. As you mentioned, Sonia, already, that over 40% of adults with learning disabilities die from pneumonia, and 24% was from community acquired and 70% was from aspiration 1. From the new guidance from the British Thoracic Society, we know that pneumonia can lead to increased hospital risk, longer hospital stay and increased rates of readmission to hospital. And therefore early detection of signs and symptoms of pneumonia is important and really requires a proactive management with people with learning disabilities, their families, their care team and other professionals to identify and manage those risk factors. Reasonable adjustments are ensure that people with learning disabilities have access to good quality of care. Working in partnership with individuals, parents, family members, carers and community partners from the onset is important to ensure that people with learning disabilities have comprehensive and accurate clinical assessment and appropriate care and treatment. And Sonia, you already mentioned some of the reasonable adjustment that individuals can make, such as having longer appointment for a longer time for an appointment, having information in an accessible or understandable format, easy read information, and making sure that preparation for an appointment is done to sending out easy read questionnaires. Making every content count approach is important in identifying risk factors for pneumonia to develop. A detailed history and clinical assessment of the respiratory health should be part of every consultation for people with learning disability, and notably at each annual health check, and should be directed at identifying risk factors for pneumonia and the need for further investigations. Annual health check introduced to people with learning disabilities from the age of 14 and over with the aim to reduce health inequalities. It provides the opportunity to identify the risk factors for pneumonia, as we know that 1.5 times increased risk of dying if people with learning disabilities have not had an annual health check in the year prior to their death. Next slide, please. The next slide will summarize the risk factors that were identified for pneumonia in the new guidance from the British Thoracic Society. As you can see, there are quite a few of them, and some individuals will only have just one or two, but some people with learning disability have a lot of them. And it's really just building the complexity of the picture, or how managing them can be difficult, but how important it is. Next slide, please. So chronic respiratory failure is a serious condition that makes it difficult to breathe on your own. And it develops when your lungs can't get enough oxygen into the blood. And it is also linked with adults with cerebral palsy have an increased risk of getting chronic respiratory failure. So as you can see from the diagram, that it can start from just with the nosy breathing and persistent cough, then leading to chest infection, that requiring antibiotics, and then having more chest infection in a year. And then some of the chest infection could lead to hospital admission. And when it's really progressive, then minor infection can lead to type 2 respiratory failure and chronic respiratory failure. The sign of symptoms of chronic respiratory failure, some of them quite obvious, but some of them not so much. There could be breathlessness, but could be change in behavior, just not really being themselves, being a bit irritable or unable to concentrate, having not daytime drowsiness, or worsening of epilepsy, headaches on walking or waking, increased chest infections, and poor sleep pattern, and sleep apnea. Next slide, please. The next risk factor that was identified in the guidance was reduced mobility, and the health benefits of exercise and its impact of respiratory functioning are well recognized. Exercise increased respiratory flow and has been shown to promote the clearance of respiratory secretion, especially from the upper peripheral airways. It is recognized that increased risk recognized in cerebral palsy, and also recognize that physical activity or mobility reduce more quickly in older adults with learning disability. Therefore, it is really important promoting physical activities and accessing activities in the community, using resources, exercise classes, swimming. That can all help. Next slide, please. So thoracic deformity as such has not been identified in the guideline as a standalone risk factor. However, we recognize it really is. And it is related to changes in the shape of the rib cage, which is very common in scoliosis and neuromuscular weakness. And what happens when you have scoliosis, so you lean, for example, towards the side, the chest or the lungs, so the lung get compressed, and there is limited expansion of your chest, and that can result in difficulty in generating a good and strong cough. So therefore, you can retain secretion, and that can lead to increased chest infections. Also recognize that when the work of breathing, so somebody will find it difficult to breathe, and combined with muscle weakness can lead to chronic respiratory failure. So therefore, it's really important when people with learning disability have thoracic deformity, scoliosis, that referral to physiotherapy assessment is made. And it is really recommended in a guideline that during clinical assessment, posture is assessed and tone is assessed. We physiotherapists in the learning disability team, this is what really we do. This is our main thing, to assess someone's posture and put in posture management, look at 24 hours management, put in equipment. But it's also really important that, for example, when someone has a scoliosis, that they refer to a specialist orthopedic team who can advise how best to manage whether a surgery is an option. Next slide, please. So the next risk factor that was identified is ineffective airway clearance and weak cough. So it's important to talk about the component of what a good cough is, what involves in having a good cough. So first is to take a deep breath, deep inspiration, and then rapid closure of the glottis with contraction of your abdominal and intercostal muscles, and then an explosive decompression of the glottis opening. And that's really what a cough is. And if one or more components are impaired, the cough will be less effective. So indicators for ineffective cough or ineffective airway clearance are nosy breathing, constant coughing, or fatiguing from coughing, having recurrent chest infection, pneumonia, or concerns about chest clearance. Therefore, really important if these signs recognize a discussion with a GP and referral to a physiotherapist to assess the cough and also to manage the airway clearance difficulty, to putting chest physiotherapy guidelines in place. Next slide, please. So the guideline recommends lung function testing, and this is really something new that recommended that spirometry is part of the respiratory assessment for people with learning disability. And this is a spirometer on the picture, and it can assess how well the lungs function, and it can trigger further assessment when required. And it also assesses the respiratory muscle strength, and the indication for it really if someone has a weak cough or poor secretion clearance. However, it is recognized that people with learning disabilities may find difficult to perform a spirometry because of sealing the mouth. It requires, following instruction, sealing the mouth around the spirometer, and therefore sometimes alternatives required, having a face mask and complete the assessment that way, or other cases might require a sniff pressure test with a specialist device. So if any concerns, a referral really need to make to a GP who can perform this assessment, and then if there is any findings that requires referral to a specialist, that is made. Next slide, please. So sleep disordered breathing is another risk factor that was identified in the guidance, and there was a link made between obstructive sleep apnea and pneumonia. And it is also recognized that when there is an increased risk for pneumonia to develop, then there is a muscle weakness which is due to neurological origin, and when people not getting enough oxygen at night. And obstructive sleep apnea is a condition when the wall of the throat relax and narrow during sleep and interrupting normal breathing. This may lead to irregularly interrupted sleep, which can have a huge impact on the quality of life and increase the risk of pneumonia to develop. And there are some conditions that link to sleep apnea, such as increased blood pressure, diabetes, asthma, or being overweight, or having enlarged tonsils. And there are some signs and symptoms that can indicate sleep apnea or sleep disordered breathing, such as excess daytime sleepiness, habitual light snoring, or actually visually observing the individual to stop breathing at night, getting up to the toilet more frequently at night, and having morning headache and nausea. And if any of these are recognized, it's important to liaise with the GP, so there is a referral can be made, for example, overnight assessment of sleep studies to be done. Next slide, please. So it is recognized that when people with learning disabilities have obstructive sleep apnea, or when they're not getting enough oxygen at night, or they have poor secretion management and recurrent chest infection, that they may require long-term assisted ventilation. So basically machine supported breathing of the individual. And the machines that you might be aware of, such as BiPAP, CPAP, VPAP. So and assisted ventilation can be delivered by a face mask, nasal mask, or a nasal pillow, or a mouth bath. And people with learning disabilities may initially find difficult to tolerate this assisted ventilation because it is quite invasive, but it is really important that reasonable adjustments are made, and working closely with the specialist services who prescribe the equipment and individuals' care team to support people with learning disabilities who required assisted ventilation to have the best opportunity to get used to it, because it really can improve their quality of life. So, and we physiotherapists can help with this work and working with the specialist services. So please let us know if you have any concerns. Next slide, please. So tracheostomy is one of the risk factors in the guideline, and it is also a management plan. So tracheostomy is when there is a hole in your neck and there is a tube inserted into the windpipe and breathing through it. There are two main indications for someone to have it. One is deterioration in respiratory function that requiring constant respiratory support, or following a period of invasive ventilation due to an acute deterioration. So in other words, if people with learning disability are really unwell and they are in ITU and they have a tracheostomy, sometimes they discharge from the hospital to community to continue having a tracheostomy and having management for it. But when decisions made, they have to be made really carefully and consideration many factors, and working very closely with the individual, their family, their care team, because there are a number of pros and cons for having tracheotomy. The pros are it can make eating easier. It can improve social interaction, because if somebody needs ventilation, not having a mask in front of their face, that can really help. But it can also stabilize somebody's respiratory health. However, the cons for having a tracheostomy that it constant intervention, so people might need suction, and also loss of ability to communicate spontaneously verbally, and dependence on trained carers to manage the tracheostomies, and also the tracheostomy complication. And the most common complication for tracheostomy is granular formulation. So basically nodules to formulate around the tracheostomy and obstruct the airway that way. So it is really important to working with the specialist services who prescribe or put this management plan in place, and feeding back to them to be aware of any problem and concerns. Next slide, please. And I think I'm going to be passing this on to Wendy. Thank you, everyone, for listening.
Thank you, Shubert, for that presentation. My name is Wendy Walker. I'm a clinical specialist speech and language therapist. I don't work in Sussex, so you won't have seen my face or my name probably. I work in London for Guy's and St Thomas's community learning disability team. So one of my specialisms is eating, drinking and swallowing difficulties in people with learning disabilities. So I'm going to take you through the next few slides, which focus on aspiration pneumonia, what are the risk factors for it, and how can we help to manage the risks for people with learning disabilities. So this is a slide is an overview that just shows the contributory factors. So eating, drinking and swallowing difficulties. For a long time, carers, professionals, people with learning disabilities have known that eating, drinking and swallowing difficulties can lead to aspiration pneumonia. But the other factors are risk factors that we have learned more about as the evidence bases have become stronger, and more things have been published from LEADER, from the British Thoracic Society, the National Patient Safety Agency. So we'll go through those one by one. Just to define aspiration, some of you will know this and some of you not, but it's when any food or fluid or saliva or acid from the stomach goes down the wrong tube in the throat. So it goes down the trachea, which is the tube that goes to our lungs, rather than the esophagus, so the tube that goes to our stomach. It's incredibly painful, incredibly distressing. It happens to everybody from time to time, but it happens much more frequently in people with learning disabilities, and particularly with severe learning disabilities. Next slide, please, Beth. Okay, so the first risk factor is around eating, drinking and swallowing difficulties. Technical term that we use, dysphagia, for that. And that can be either difficulty with chewing, food or problems with swallowing the food. Again, it's much higher incidence of problems with eating, drinking and swallowing difficulties in people with learning disabilities, particularly for people who have cerebral palsy. The up to 60% of people have problems with dysphagia with swallowing. And we've already talked about some of the preventable deaths around aspiration pneumonia, that 16% are thought to have been related to aspiration pneumonia. The impact on secretion management and that can lead to malnutrition and dehydration and lead to aspiration and pneumonia. It's really important if you think that someone's having, as carers, if you think that someone's having problems with chewing their food or swallowing their food, that you refer on to the speech language therapy team locally in Sussex, and they might ask you to do some monitoring and give you some guidelines about how to support people. Next slide, please, Beth. Okay, so the British Thoracic Society identified gastroesophageal reflux, so reflux of the stomach acid coming up from the stomach into the throat, as being a big contributory factor to pneumonia if people are aspirating. So it can be really difficult to recognize in people with learning disabilities because they often can't tell you if they have pain. It's much higher incidence in people who have a neurodisability, and it really needs referral on to specialist services for investigation. The investigations can be quite invasive, so they're not always well tolerated by adults with learning disabilities. Next slide, please, Beth. Okay, so the reflux happens for a number of reasons, and it's where the stomach contents or the stomach acid goes into the esophagus. It might have bacteria in it, it's certainly acidic, so it's a caustic substance, and it leads to pain and damage to the esophagus, but it also is very poorly tolerated by the lungs. They don't like it, causes infections, and can lead to aspiration pneumonia. So the things that you might notice in the people that you're caring for are things like refusing to eat or drink because it's really painful and it's really unpleasant condition. You might see them starting to lose weight. For those people that can tell you, they often have pain in their chest or pain in their stomach. And some of the people I work with who are able to describe that, describe it as thinking they're having a heart attack. It's so painful and so unpleasant for them. You might see vomiting, or they might vomit and there can be blood in it. It's really important to speak to a GP if you suspect that any of the people you're caring for are having gastroesophageal reflux, because there's lots of things that the GPs can give in terms of medication. Our physios can also help with posture so that the reflux is not coming up so much. And people moving around. There's also lifestyle changes that people can make. So the type of food that they eat, eating spicy food, eating late at night, being overweight, smoking, drinking alcohol, can all make people experience more reflux. Next slide, please, Beth. So the other indicator is people having difficulty controlling or managing their oral secretions. This is really common in people who have neurodisability, people with cerebral palsy, people with more severe learning disabilities. And it can cause saliva to either come out of someone's mouth in drooling, or it can pool in the back of their throat. And I think, Sonia, you mentioned this in your presentation about how unpleasant that pooling in the back of the throat is. It's not always that people with learning disabilities necessarily are producing more saliva than other people. So we all produce up to 1.5 litres of saliva every day, but we swallow it. So we're not aware that we're doing it. So it's only when someone's unable to swallow it, or they're not aware that it's building up in their mouth, that they become more aware about that. The things that can be helpful, so referring to the GP, because medications, there's kind of first line medications that the GPs can give. There's patches that people can have on their throat. There's also Botox injections and the surgical things that can help with this. This can be particularly difficult for people at night when they're in a lying down position and the secretions pool a lot more. If the secretions are pooling, they can also be aspirated into the lungs and set up infections. Okay, next slide, please, Beth. So oral health. We know that people with learning disabilities experience more problems with their oral health than the general population. That's a combination of maybe being fearful of going to the dentist, maybe not being able to access a dentist, not being able to access a dentist that is specialist enough or can make the reasonable adjustments necessary. So poor oral health means that there's more likelihood that there is bacteria building up in people's mouths, in their saliva, in their food, in their fluids, and that grows. That grows in the mouth, and if that is then aspirated, so if it goes down the wrong tube towards the lungs, it's more likely to cause infection. Even small amounts of this, even micro aspiration, can cause aspiration pneumonia very quickly. So it's really important. I think when I go and work with families and carers, they're often surprised that I'm talking so much about oral health when I'm going to assess somebody's mealtime or their swallow, but it really is very, very important. And it's a place where carers have a massive role. You really are crucial to this aspect of people's care. Next slide, please, Beth. Okay, so the link between oral hygiene and respiratory disease is very high. There's very well correlated, lots of evidence telling us that in people with learning disabilities, but also in older populations of people. And so it's really important that mouth care takes a really high priority in all care settings. So in supported living, but also in nursing care. It can be quite scary for people with learning disabilities, particularly if they need to be fully supported or partially supported with their teeth brushing, with going to the dentist, and they may need a period of desensitization. So they may need to become accustomed to these procedures to be able to improve their oral health. Next slide, please. So, as carers, what can you do to make sure that the person you're supporting, you're helping, has the best oral health possible? So it's recommended that people are supported to brush their teeth, or that we all brush our teeth 2 times a day, and that we use fluoride toothpaste. If somebody finds toothbrushing really difficult or offensive, they don't tolerate it well, it may be that you may want to support them, prompt them to brush their teeth more than twice a day, but for a shorter period of time, or before or after meals. Non-foaming toothpastes are available. You can buy them over the counter, but you can also get them from your dentist. And these reduce the risk that someone is going to swallow the foam from the toothpaste. And it's also makes it a little bit more easy for people who might have difficulty spitting out the toothpaste as well. So there's not so much build-up in their mouths. Care settings have said that it's really helpful if they can identify oral health champions. So the person who makes sure that everybody's had their dental checkups, having their teeth brushed, knows about the different products available, maybe has a direct contact to the dentists and the special dentists. And again, as we've said about in annual health checks, it's really helpful to also check that someone's had an oral health check, that they've been to a dentist, either a specialist dentist or for some people a high street dentist. Thank you, Beth. Can I have the next slide? Okay. Poorly controlled seizures have been identified as a huge factor in sorry, that was my phone, everybody. Forgot to turn off my work phone. As a big factor, a big contributory factor to aspiration and aspiration pneumonia. And this is because if somebody's seizures are not well controlled during the period before a seizure or during the seizure or after the seizure, they're likely to be more drowsy. They're likely to not have the same level of awareness as they would previously, and so at other times, and so they're more likely to aspirate their saliva. If they're eating and drinking, definitely more likely to aspirate it. And also aspirating vomit. When people have seizures, that's quite a common thing that happens, and so you can imagine that vomit is going towards the lungs and again setting up more of an infection. It's really important to follow the national guidance. So there's NICE guidelines around epilepsy management, and everybody that is identified as having epilepsy should have an epilepsy care plan, which should be followed. If there are any changes to someone's seizure pattern to their epilepsy, it's important that that's flagged with their GP or their neurologist. Thank you, Beth. Okay, so in summary, early identification, early intervention around all of these risk factors and the involvement of speech language therapy is key. It's important though that we acknowledge that any changes, any investigations or any changes that we might be suggesting to make to people's meal times, swallowing, medication, that their mental capacity is assessed, but also that we're weighing up their preferences with what the evidence is telling us, and working with people with learning disabilities and their carers to find out what their personal choices, their food preferences. Aspiration pneumonia is quite a complex concept for many people to understand. But even if they are unable to understand the risks, most people have preferences around their food, around the flavor, the texture, the timing of their food. So it's really helpful if we can get that information about personal choice from somebody, so that we're not changing their meal times or restricting their diet. There are medications that are associated with eating, drinking, and swallowing difficulties, which can affect the way people chew their food, and also cause a dry mouth, and it can cause drowsiness. So that can really impact on someone's eating, drinking, and swallowing. There are surgical procedures that can help with reduce people's gastroesophageal reflux, like this one that's mentioned here, fundoplication. And also some people may have a feeding tube into their stomach or into a different part of their intestine to receive their food, their fluid and their medication through that tube. But again, that needs to be really carefully considered, and the person's preference or their capacity to make decisions around that. It's difficult in people with learning disabilities, particularly people with severe learning disabilities. It's unlikely that as a speech language therapist or a carer, we're going to be able to show them any techniques to improve their swallow. So these optimizing the other risk factors, so improving people's oral health, reducing gastroesophageal reflux, making sure that their seizures are really well managed is absolutely important, along with their posture, which is where our physios help us a lot with that, and also trying to enable people to retain some independence with eating and drinking. So we know that some of the other research shows that if somebody is fully supported, so if they not holding their spoon, they're not holding their cup, they're much more at risk of aspiration. So our occupational therapy colleagues help a lot with supporting people to be able to at least participate in some way in their meal times. Okay, I am passing on now. So if anybody's got any questions, please put them in the chat. And I am passing on to Jeanette, not to Jeanette, to Michelle. Sorry, Michelle. Thank you.
Hi there, everybody. It's lovely to be here. My name is Michelle Cruchandle, and I'm lead clinical pharmacist in learning disabilities working for Sussex Partnership. So I carry out something called STOMP medication reviews, and STOMP stands for Stopping the Over-Medication of People with a Learning Disability, Autism, or both. And it's really important that people with a learning disability are on the right medications for them. Psychotropic medications are medications that act on your brain or your mind, and examples of these will be things like antipsychotics, antidepressants, and hypnotics, so medications that can help you sleep or can sedate you. Also, people with a learning disability are much more likely, 16 times more likely, to be prescribed an antipsychotic. And sometimes these mental health medications can be prescribed for behaviours that challenge. We need to make sure that at our annual health check, and at the annual health check, there is a medication review that is carried out, usually by the GP or a pharmacist, hopefully. And we need to make sure that people are on the right medications and that they're not being over-medicated and they're not suffering from any unwanted side effects. And they need to be on the lowest doses that are possible of these types of medications for the shortest periods of time. The use of antipsychotics, I'm pleased to say, and other psychotropic or mental health medications is slowly decreasing since the STOMP call to action back in 2016. But there's still much work to be done here. Moving on to the next slide, please. So now I'm going to talk a bit about medication and how it can affect swallowing. And so Wendy and some of the other people that have been presenting have explained about dysphagia, which is difficulty in swallowing, and how that increases the risk of pneumonia. And so people with a learning disability, we know, suffer from more physical and mental health conditions, so are much more likely to be on lots of different medications. So some of these drugs can damage the esophagus or the food pipe by causing local irritation. So examples of medications that can cause this local irritation are usually acidic types of medications, such as alendronic acid, which is used for osteoporosis, ibuprofen, which is used as a painkiller, and some antibiotics. And what's really, really important is that when we take our medications, that we sit upright and we drink enough water to wash those tablets and capsules down our food pipes. And if you can't swallow the tablets and capsules, then there are liquid formulations of medications that may be available instead. So medications can affect they can depress the central nervous system. And what this can do is it can cause sedation, and it can slow down brain activity, which can affect swallowing. And medications that can cause this are things like anti-epileptic medications, such as sodium valproate and carbamazepine. And then there's things like hypnotics, benzodiazepines, and painkillers such as codeine. So all of these medications can decrease awareness and voluntary muscle control and may affect swallowing. Medications can affect the muscles of the esophagus. And Wendy mentioned about these anticholinergic drugs such as hyoscine, and they can affect the swallowing. They can also cause dry mouth, so can impair the ability to move food around. Examples of these sorts of medications may be things like oxybutynin and procyclidine. Also, when you visit your dentist, they may give you a local anaesthetic, which can be used when you've had a filling or something like that. And that may cause loss of sensation, so it may affect the swallowing until it wears off. And it can take some time, can't it, before that wears off. And finally, last but not least, just to mention a little bit more about antipsychotics. So antipsychotics can affect swallowing in quite a few different ways. So they can have anticholinergic side effects, so they can affect the muscles in the esophagus. They can cause dry mouth, and they can also cause something called extrapyramidal side effects. So extrapyramidal side effects are involuntary muscle movements which can affect your face and your tongue and actually the whole body, and such as may be seen in someone suffering from Parkinson's disease. And examples of antipsychotics will be things like haloperidol, zeucoplentixol, chlorpromazine, and some of the newer antipsychotics at higher doses, such as risperidone. So these medications can all affect your swallowing. Thank you very much for listening.
Hi everyone. I can see quite a few familiar faces and names, but for those who I've not met, I'm Lizzie McWilliams, and I'm a physio in the Learning Disability team, and worked over in West Sussex for a while, but I'm working in East more recently. So I'm just going to be talking to you about the other risk factors that haven't been talked about yet. And after that, we're going to finish off with a case study. So the first risk factor I want to speak about is around vaccinations. So the BTS guidelines that came out this year, state that people with a learning disability should be considered as a high priority in all vaccination programs for seasonal respiratory infections. We know that there's a lower uptake of vaccines in people with learning disabilities, and the research also shows that vaccines can reduce hospitalizations with pneumonia. So in light of this, vaccine history is recommended to be reviewed at every opportunity. So things like the annual flu vaccine, that's recommended for all people with a learning disability. The pneumococcal vaccination, it should be considered for clinically high risk groups. So that's people with chronic respiratory disease. And although learning disabilities isn't actually a recommended clinical high risk group, a lot of people, as you're aware, have respiratory disease. People with learning disabilities have a high incidence of respiratory disease. So it should be considered really. And what the guidelines recommend is that people have a one-off pneumococcal vaccine, and that offers long-term protection. Unless you have no spleen or reduced splenic function or renal disease, in which case they recommend a booster every 5 years. So for you, for carers and providers, it's important that you're checking if your people that you work with who have a learning disability have had their flu vaccine, and also consider whether a pneumococcal vaccine is necessary, and you might need the help of the GP to work that out, so you can always liaise with the GP. Next slide, please, Beth. Okay, so being underweight is associated with an increased risk of pneumonia, and contributing factors include changes to the respiratory muscles. So people end up with quite a weak cough, or then they're unable to expectorate secretions and sputum out of their lungs because their muscles aren't working properly. The research around the risks of being overweight or obese are quite inconsistent, but we know that people who are obese or overweight, there's a link with sleep apnea, reflux, and reduced mobility, and we know that they negatively impact on respiratory health. Being underweight and obese are more common in people with learning disabilities, and specific learning disability diagnoses are associated with an increased risk of obesity in things like Down syndrome, Prader-Willi syndrome, and diagnoses such as autism can be associated with sensory feeding aspects that lead to restricted diet, malnutrition. So the identification of being underweight or overweight is really important, and we should be making sure that people who are overweight or underweight are monitored and get the right input from the GP and dietitians as needed. Just important to note as well that the guidelines state that that BMI it poorly reflects body composition in individuals with neurological impairment, which is common in learning disabilities. So we should be considering using skin fold thickness instead. Next slide, please, Beth. So you should see on the slide some of the management strategies for people who are underweight. Some of these you'll be familiar with, but I'll just quickly run through them. You want to be optimizing the mealtime environment and the routine. You want to be making sure that people have really good postural management, that they're positioned well, that the parent or caregiver is using a good technique. We know that hurried feeding can lead to aspiration, so it's really important that time is taken, that you use the right adaptive equipment as needed, and also that people are getting the right calorie supplementation. Things that you can do are, if someone's underweight and you don't think these things are being managed well, are to follow these guidelines, and also to help also consider referring to the GP. And making sure that there's a really good nutritional care plan in place by a specialist. Next slide, please, Beth. So every opportunity should be taken to review smoking and environmental tobacco smoke exposure, and smoking and cessation advice should be offered and referred on to for people who are either current smokers or where you identify that somebody is exposed to smoke because of their environment. Next slide, please. So we know that comorbid conditions such as, you can see a few on the slide there, heart disease, COPD, diabetes, liver disease, these sorts of conditions can increase your risk of acquiring chest infections. So it's really important that these other health conditions are managed optimally, and that they're monitored and reviewed by the GP and other relevant specialists as needed. Next slide, please, Beth. So the research shows that having a previous episode of pneumonia indicates an increased risk of subsequent pneumonia. And that's particularly high in cerebral palsy, where we know that if somebody has a hospital admission with a chest infection, that there's a 50% increased chance of a hospitalization with another chest infection in the next 12 months, which is really staggeringly high. So the fact that somebody has had a chest infection shouldn't go unnoticed, and should flag that actually we need to make sure that risk factors are being managed properly. So you need to discuss it with the GP and raise it at annual health checks. Next slide, please, Beth. So bacterial colonization. So this is where you get gram-negative organisms like Pseudomonas growing in your lungs. And we know that when somebody has Pseudomonas growing in their lungs or any other bacteria, that there is an increased risk of hospitalization and being admitted to critical care during that hospital admission. And we also know it's associated with longer hospital admissions. So the guidelines recommend that we are actually taking a specimen and checking what is in the sputum. And also then, if we're finding that there is bacteria in the sputum, that we're considering using long-term nebulized antibiotics. And the reason for that is that, you know, we're trying to actually treat that bacteria. The other thing to mention here is around immunodeficiency. So it's a feature of several learning disability associated syndromes like Down syndrome and DeGeorge syndrome. We know that in these types of conditions that people are less able to fight off infection, and actually we should really be considering whether bacteria is playing a part. So next slide, please, Beth. So in frequent exacerbations of pneumonia, the guidelines recommend that if somebody has over 3 episodes a year or over 2 hospitalizations with pneumonia a year, that prophylactic antibiotics is considered. The first line antibiotic they recommend is azithromycin, because of it has quite good anti-inflammatory properties, and it has quite a long half-life as well, so it lingers around in the system for longer than other medications. The effect of the antibiotic needs to be reviewed over time, which is a given really. You know, you don't want to start somebody on an antibiotic and just leave it. It needs reviewed regularly to check the efficacy and check if it's working, check whether it needs to be changed to something else. But importantly, the side effects should be considered, because with, for example, a long-term nebulized antibiotic, there's risk that it could cause some bronchospasm, which is where the muscles in the lungs tighten and can cause things like a wheeze. So a test needs to be done prior to starting anybody on a medication like that. And also it's important to say as well that in people with learning disabilities, they often have more sensitive lungs, so lower doses are often recommended rather than in somebody with a healthy lung. Next slide, please, Beth. So these are just a couple of other contributory factors. One of them is constipation, which we know is very common in our population, and we need to, the reason why constipation affects the lungs is that it can increase reflux, and it can increase salivation, and it can lead to breathlessness. So we know that if we manage constipation well, that we can help reduce the effects on chest health. So the other one there is diarrhea. We know that dehydration can lead to drying of the mucosal linings in the body, including in the lungs. So you know, having the mucosal lining dry out in your lungs increases your risk of acquiring infections. So 2 really important ones there. And I think the key points on this slide really are that we're identifying the symptoms of constipation and diarrhea, and making sure that they're both managed properly via the GP or dietitian. And next slide, please, Beth. So I think we're on to our case study. So this is a case study of a man that I spent a bit of time with in East Sussex, or West Sussex. He's left Sussex now, but and I've changed his name for confidentiality. But he's a 30-year-old man, and he lived in supported living at the time. Sorry, at the time we supported him, he was in nursing, in a nursing home, and he liked spending time with his family. He loved being out in town. He loved being out on the seafront, His conditions include cerebral palsy and pseudobulbar palsy, which some of you might know what that is, but if you don't, it's a condition that affects the nerves in the face and the throat, and effectively you can end up with facial weakness, tongue weakness, and a reduced ability to swallow effectively. He also had epilepsy and asthma. So when we were referred to Tom, he'd had 5 chest infections in the previous year with 3 prolonged hospital admissions. And we identified his risks initially, and they're outlined on the slide there, but just to summarize, he had immobility, he was a full-time wheelchair user, he had really poor swallow efficiency, so he was fully peg fed. He had a really weak cough. He had pulling of secretions at the back of his throat, so you could just constantly hear this noisy breathing. He also had a persistent cough, and he had severe anterior drooling out the front of his mouth when he was sitting up in his chair. But when he was laid flat, there was no drooling, which would indicate that potentially some of the pulling of secretions was just being aspirated. He also had a really severe thoracic deformity. So he had a really big S-shaped curve in his spine, and his up high on his back was really curved as well. And that affected lung entry into the bottom of his lungs. So when we listened with the stethoscope, it was pretty much silent at the bottom of his lungs. And when he takes a breath in, his lungs don't move. So there was just no expansion, very rigid throughout his rib cage. So yeah, he also had reflux. Next slide, please, Beth. So this is how we helped Tom. We put in place a new 24-hour postural routine, which included more postural changes throughout the 24-hour cycle. So instead of just going bed to chair once or twice a day, we were doing more time in the bed, more time in a different type of chair, in a postural armchair, in different positions. We also provided some mat time as well, and more of a movement program. We also put in a lying support and got him onto his side more often to reduce that risk of aspirating on his saliva. We got him a tilt and space bed so we could raise the head of the bed up and reduce that risk of reflux, aspirating on reflux. We put a portable suction machine onto his wheelchair so that he could have an improved clearance of his saliva and secretions in a more timely way. So it's there and he has access to it right away when he needs it. We referred to wheelchair service, and they provided a new molded seat that better managed his posture and better managed his thoracic deformity to reduce the chance of that getting worse and the impact that would have on his lungs. We referred to GP, and they changed some medications around reflux and saliva. We also referred to the specialist respiratory service, and he was reviewed at the Liam Fox unit. They did some medication changes as well, which helped, and they also did an overnight sleep assessment. He was also referred to neurology because he hadn't had a review of his pseudobulbar palsy or epilepsy for many years. And we also referred to dietetics, and he had some support with low weight. Next slide, please, Beth. So in the last year, Tom's had no chest infections and he's had no hospital admissions. He's got a much better cough. He's got less pulling at the back of his throat, and the noisy breathing is pretty much non-existent. He has reduced drooling anteriorly, and the likelihood is that there's less drooling posteriorly back into the lungs as well, as the saliva is better managed. And he has had an all-round improvement in his quality of life. That's it from me, but if there's any questions, just pop them in the chat or at the end, and I'm going to hand over to Ursbeth for the final few slides. Thank you very much for listening.
Thank you, Lizzie, and thank you for presenting Tom to us. And this slide really links in with what you just told us, and it shows that how many professionals involved in a person's life when trying to manage their pneumonia. And as you can see, you know, we talked about the role of the speech and language therapist, physiotherapist, GP, dental services, having a specialist respiratory service, or working with locally with respiratory consultant, pharmacist, like Michelle's role, and working with the acute learning disability liaison team in a hospital when people with learning disabilities are admitted to hospital to support them there, dietitian, and last but not least, the care team and family members who are looking after people with learning disabilities. It is so important having a multidisciplinary approach involving everyone and putting in the center of care the individual with a respiratory problem, pneumonia, and trying to manage it better and identifying the risk factor and ultimately to improve the quality of life. I'm going to pass it on to Maxine now to finish off our webinar. But thank you so much for coming and listening to us. Thank you.
Thanks, Elizabeth. And thanks everybody for all of those presentations and all of that information. I hope it was useful for people, and we've had a few things come into the chat which we can have a little chat about in a minute. I think sort of one of the things that I just wanted to finish off by saying really is that the change that I've noticed and the change that is really happening at the moment is that, you know, we are working together more, and it needs to improve, but we're working together more to identify people's risks and have them better managed in the community. So really the results of all of this work should be that people have a sort of community level respiratory care plan where all the people who support them have kind of contributed to. And it's really, you know, the focus of that care plan is to minimize the risks as much as possible and to keep that person as well as possible, so that they can get on with the other things in the life that they enjoy doing. So I think now what we're going to do so we've got a couple of things that come up in the chat. We haven't got a lot of questions, but we have got a bit of time that we could have a little sort of a few questions if there were any at this point. But I think, Beth, have we got a slide? Because I think, are we going to re-poll at this point and ask people? Yeah. So we're just going to ask you at this point to answer the questions again and just see, now that we've kind of gone through some of the information, some of you will have been very well aware of a lot of it, but there may have been some things that have been kind of, you know, improved your overall sort of knowledge and your awareness of the things that you need to be looking out for and the things that you should be thinking about getting help for.
Maxine, I can't hear you, but
Oh, sorry.
I think, but I think that's probably about it. Most people think you can do. Yeah, I can hear you now.
Oh, okay.
So I'll share. If I end it now, and share what's come in.
Great. Okay, so that's lovely to see. It feels like we've moved kind of up the scale in terms of how people feel about kind of the awareness of some of the issues and the knowledge. So I hope we haven't had much on the Padlet, and that's fine. I think, to be honest, you know, if it's just sort of kind of stimulated you to think about the people who you support and take things further, go and have a chat with the GP, you know, have a chat with the other kind of people who are supporting you, the other health professionals, and just, I suppose, being more observant and aware of some of these symptoms and getting help for them. What we're going to do now is just, we've got a couple of, one of the things that I thought that came up in the chat earlier on, oh, sorry, Beth, we've got contacts there. So we've got contacts and our emails, which we can share. And what we're going to do is share the slides with you all at the end, and also hopefully a link to the recording of the webinar. So we've got questions coming into the chat now, which is brilliant. And what I thought we'd do is, if we come off the presentation, that's it. Right. So earlier on, it was just to mention, there was a little sort of conversation that happened around pillows on the bed and propping somebody up and that sort of thing. And I've put a little bit of an answer into the chat. So and it was just really about the raising of the head of the bed. So there is this sort of general agreement about raising the head of the bed having an effect on reflux for people and helping with those symptoms overnight. But you just need to be a little bit careful, as I've said in the chat. If someone's got postural difficulties, it might be worth getting a bit of advice around that, because as soon as you raise the head of the bed, if someone has some weakness and they can't maintain their position in that raised position, sometimes you might find then they end up leaning more and causing more problems. So just get some advice at that point from physio. And then Karen Ali has shared with us a couple of documents, which I don't think I've seen. So a bit of latest research about head of the bed. So that's in the chat, so go and have a look at that. And also the issue around sort of moving after a meal time, so how long you leave it before you lie down and move around after a meal time. So again, that's something to really, you know, kind of pay attention to and consider when people can't communicate their symptoms. I know in some of the work that we do, quite often we're sort of, you know, working with teams and helping. We are often identifying that some of the ways that people are communicating and distress they might be communicating does end up being, you know, reflux, symptoms of reflux that can just be hidden for quite a long time. So it's everybody being sort of super aware of that and talking to the GP if you suspect. So, oh, sorry, Becca, I think you've got your microphone on there. Or was that a question? Don't know. So Daniela, who's sharing the slides, and a risk assessment template. And can I have a copy of the slide? So Stacey, is that a risk assessment template for, could you clarify that?
It was something someone mentioned before about a risk assessment for the breathing difficulties and the after chest infections. I don't know if there's a template for the risk assessment for that.
Not sure about that. I mean, I don't know, was that?
I think I meant the respiratory care plan.
Oh, okay. So yeah, so essentially what we're doing at the moment when we do a respiratory assessment, so the physios from the learning disability teams, we're using a template, if you like, which looks at, it will ask questions all about the different risks. And then will start to work with the person and their GP. It's triggering off more now than it was before, referrals to specialist respiratory services. So we should be expecting a bit more of that where it's needed. So where those assessments, identify issues that don't seem to be very well managed at community level. If the GP isn't too confident, if there's combinations of medications like saliva management or medication to loosen secretions or something like that, then we're much more now asking GPs to refer to the respiratory consultants to get help with that, because they're much more experienced at kind of making the adjustments around the medical management of the respiratory condition. So yeah, Stacey, what you're saying there in terms of a risk assessment, that's something that we would work with you to look at all the risks, and it may be something that we could think about developing in terms of something quite easy that we could, some sort of checklist that we could give out like we have done in the past with the FORS risk assessment.
I think sorry, she was seen by SALT last year, and then she's had chest infection this year, but she doesn't like to sit too close to the table, and she obviously sits sort of bent over. So obviously after looking at the training today, there's obviously a risk with how she swallows her food and things like that. So
yeah, so I don't know, Wendy, did you want to come in on that? Is it worth? Sorry, Wendy.
Sorry, Maxine, was that a question for me? I just got kicked out for some reason.
Yeah, so Stacey, do you want to just
just repeat it, Stacey, please?
yes, sorry. One of our ladies was seen by SALT last year, and there were no issues surrounding sort of what she ate, apart from having a sort of a mixed consistency. But she has recently been discharged from hospital after having a chest infection, and she doesn't like sitting close to the table or sitting upright, and she will sort of sit bent at the hips, let's say, at the table. So would you advise having a risk assessment or input from a GP?
I would advise, if she's had a recent chest infection, that I think in Sussex you need your GPs to refer back to speech therapy.
Yeah. And it also sounds like
physio
might also need to do with speech and language therapy there, because you're mentioning some postural issues.
Posture, yeah.
It may be that a bit of a review needs to be done around the swallow, but also looking at the postural issues. And I think what also seems to be happening at the moment is, so if someone has been in hospital for a chest infection, and then you're thinking, okay, there are a combination of risk factors here, and I don't think they're managed as well as they could be. Having an assessment in the community by the physio team can help to sort of just review all those risk factors. So it can be combined with the speech and language therapist for eating and drinking. And that's a general, so obviously the current chest infection has been treated, and what you're doing now is looking to prevent further in the future. So you're looking to get things as good as they can be now for the future, because I can see Daryl's put something there about GP and getting antibiotics as soon as something's suspected.
Sorry, just another thing, her postural thing, she's always sort of bent over eating. It's not anything new, but obviously since the chest infection, obviously there's obviously a high risk, I guess.
Yeah, and sometimes people, that can cause more weakness, and people can sort of not be quite back where they were before. So if you think there's any risk to the eating and drinking, then it is worth getting a review of that.
I would definitely get a review.
That would be talked to the GP.
Yeah, because also if the person's unwell, then that also puts them at greater risk of aspiration. So they're not going to be swallowing as well as when they've not been unwell.
Yeah.
So I definitely get that reviewed, Stacey.
Yeah. Lizzie, I don't know if you want to answer Daryl's question there about should the GP, because I think there's been conversations about this, hasn't there? And
yeah, I mean, in terms of the, hi Daryl, in terms of the question about should the GP prescribe antibiotics as soon as a chest infection is suspected, that's really down to the, I mean, the answer to that is if there's a chest infection and they feel like they need treatment, the quicker they get the treatment, the better, really. So in answer to that question, I would say yes, as soon as possible. However, each individual case would need to be taken on its own merit, because some people, for example, might have had lots and lots and lots of antibiotics and they're not working, or they need, you know, there's lots of different things that are individual to a person. But in answer to your question, as soon as, yes, I'd say as soon as possible is going to be better than waiting. And the other thing I'd say is around difficult to get prompt help when show signs of deterioration. Some people have got, as I mentioned in the presentation, some people have got are on prophylactic antibiotics, but if they're not on prophylactic antibiotics and they're just having antibiotics as and when a chest infection happens, some people have like have antibiotics that they have at home ready to use as well. So a bit of a rescue pack ready to go. So that could be discussed with your GP. You could discuss with them that you're having issues with getting antibiotics on board as soon as your person has a chest infection, and is there any way you could have a rescue pack with antibiotics at home. But obviously you need to know how and when to give those, and there needs to be a clear plan around that with the GP's help. And we've also got Michelle, pharmacy, here as well. So I don't know whether you have anything to add, Michelle, to that, or.
I would agree with everything you said. Yeah, I think if it's somebody that is having several chest infections and admissions for pneumonia, then you would probably prescribe something as soon as possible, and maybe try and take a sputum sample if possible to see whether what sort of antibiotics are effective. Would you ever recommend that, Lizzie, at all?
Yeah, I mean, getting a sputum sample can be tricky, but I think if it depends on your GP surgery and what other like some have got physios working out clinics there, and they have better setups. But I think the key thing is that if somebody is getting regular chest infections, that a sputum sample is taken and used. So to guide antibiotic treatment, yeah, definitely. So that would be advisable. If somebody's getting regular chest infections, I would advise that they have a sputum sample, and the guidelines recommend that somebody does have their sputum analysed to see if there's bacteria colonizing, and just to help guide the treatment, really.
Yeah.
But I hope that's
sorry to say, I was going to say, to see which antibiotic would be working against that bacteria in particular.
Yeah,
be sensitive to it. Yeah,
exactly. Yeah, to get the right antibiotic. So if your issue is around delay in intervention, then I think a discussion needs to be had with your GP around how you can overcome that. And one of the ways that we would suggest would be to have a rescue pack at home if needed, and with a clear care plan on when to administer and how much, and in what instances to administer. So that would be my advice, Daryl. I hope that's helpful.
Thank you very much. Thanks.
Thanks, Lizzie. Thanks, Daryl. So unless anyone else can see in the chat, do you have format for a generic respiratory? Oh yeah, so that was the generic respiratory cover. We don't at the moment, do we? We sort of draw up care plans specifically when we are, but that could be, Liam put that in the chat, that could be something that we look at to develop as part of the work that we're doing as we go along, if that would be helpful.
Yeah, I was just going to say, Maxine, so if somebody's referred to us, we would come and do the risk assessment, and we'd write a care plan to manage the risks. But for carers to identify the risks, I mean, today in this presentation, we've gone through all of the risks, but you could almost use it as a checklist those risk factors as a checklist, and if things are flagging up that a person has and aren't being managed and aren't being optimized, then you could use this presentation as a means to work out what you need to do next. So we'll be sharing the presentation with you, won't we, Maxine? So you'll have access to all of the risks and how they should be managed in that presentation, and know who to signpost to or refer to, and where to get the help that you need, really. So it should all be in the presentation, Maxine, shouldn't it? So
yeah, and that's a good point. I think that's one of the things we could take forward is watch this space a bit, really, because if a generic kind of respiratory care plan type thing would be helpful for care settings or for any sort of setting, really, to be able to sort of describe that for the person, then might be something that we could think about. So, are there any other questions at this point? Karen's got to go. That's all right. Thanks, Karen. No other questions coming into the chat or anything coming from anybody. So that is wonderful. You're going to have a bit of time before you have to either go into another meeting or whatever you've got to do. So I'm just going to close the webinar now and just say thank you, really, to everybody that has come along today. I hope you found it useful. We'll send out all of our contacts. Please get in touch if you want to discuss anything.